The webinar will now begin.
Hello, everyone, and welcome to the first in our series of evidence-based guidelines webinars. Today, we will be talking about the exome and genome sequencing for pediatric patients with congenital anomalies or intellectual disability, an evidence-based guideline, clinical guideline of the American College of Medical Genetics and Genomics. We'd like to thank and acknowledge the National Coordinating Center for the Regional Genetics Network's funding acknowledgement. This project is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under Cooperative Agreement UH9MC30770 from June 2020 to May 2024. For $800,000 per calendar year. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the US government. Today's speaker is Dr. Murugu Manikan. He received his medical degree at the Royal College of Surgeons in Ireland, and then obtained a master's in public health from the University of North Carolina in Chapel Hill. He is doubly board certified in internal medicine and clinical genetics and genomics. He is currently at the Nationwide Children's Hospital in Columbus, Ohio in the Department of Pediatrics and at OSU Wexner Medical Center in Columbus, Ohio in the Department of Internal Medicine. His clinical interests include genetic testing, health disparities, and specialty care for Down syndrome and neurofibromatosis. There's educational credit available for today's webinar. The American College of Medical Genetics and Genomics is accredited by the Accreditation Council for Continuing Medical Education, ACCME, to provide continuing medical education for physicians. The American College of Medical Genetics and Genomics designates this live activity for a maximum of one AMA PRA Credit 1, Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in this activity. To obtain your credit, please complete the activity and carefully complete the evaluation form. The deadline to claim educational credits is within 30 days from the date of the activity. Educational credit requests after this date will not be accepted. Thank you. The ACMG educational programs are designed primarily as an educational tool for healthcare providers who wish to increase their understanding of the application of genomic technologies to patient care. The ACMG does not endorse or recommend the use of this educational program to make patient diagnoses, particularly by individuals not trained in medical genetics. Adherence to the information provided in these programs does not necessarily ensure a successful diagnostic outcome. The program should not be considered inclusive of all proper procedures and/or exclusive of other procedures and that are reasonably directed at obtaining the same results. In determining the propriety of any specific procedure, a healthcare provider should apply his or her own professional judgment to the specific clinical circumstances presented by the individual patient or specimen. The following members of the planning committee and today's presenter have nothing to disclose. To submit a question, please use the Q&A feature, which is located at the bottom of your Zoom window screen. Use the chat only for indicating technical issues. To help prioritize a question, which is called upvoting, please give it a thumbs up. At the conclusion of today's activity, participants should be able to describe the systematic evidence review process, identify 2 criteria used to determine if a study should be included in the systematic review, and explain 2 pieces of evidence that were used to support the ACMG recommendation. Dr. Manikim, I will turn the presentation over to you now.
Thank you very much. Let's turn on my video. All right, so we'll go over an outline for today's presentation. We'll talk about the rationale for developing guidelines, the evidence that is used, and then the evidence to create a recommendation. And finally, we will conclude with talking about the implementation of these guidelines. So the overall rationale for developing these guidelines was based on the fact that the ACMG recognized that exome sequencing is becoming part of our clinical management. The kind of analytic framework is shown on the left, starting with the idea that congenital anomalies and developmental delay, as well as intellectual disability, are among the most common indications for genetics referral in the pediatric population. But obviously, as most of the people on this call are aware, that these are often heterogeneous conditions, that there can be literally thousands of potential conditions that fall under this heading. The premise would be that early diagnosis will change patient management, reduce mortality, reduce morbidity, improve health outcomes, and inform reproductive decisions. Additional considerations could be health resource utilization, cost effectiveness, and educational planning. So why guidelines now? The diagnostic odyssey is typically years between getting a referral placed for genetics evaluation, getting into a clinic, and then getting testing approved, drawn and sent, and then resulted, and then repeated for multiple types of tests. This is obviously frustrating for everyone involved, for patients, for families, and for us as clinicians. The time and cost utilization can also be quite high. We may need to do broad screens as just in case, and in these cases, it may also involve sedation, which creates a different risk for patients. Existing recommendations predate next generation sequencing methods, including large gene panels, exome sequencing, and genome sequencing. And the reimbursement landscape is variable between insurance plans, institutions, and situations. Many of us will remember or even still dealing with the microarray introduction. Pardon me. When microarrays were introduced, that created both challenges for workflow, but also for coverage. And at the end of the day, health plans and hospitals, and really us, we want evidence of improved outcomes from getting a diagnosis or the use of exomes. So the guideline process really has 5 components. The ACMG will solicit nominations from ACMG members, fellows, and other stakeholders twice a year, typically in the spring and fall. The ACMG methodologist and topic selection committee will appraise the potential for nominated topics to yield a systematic evidence review. Topics are then assessed by the committee for alignment to the college's priorities, anticipated impact, feasibility, and methodology, as well as the available evidence. Separate work groups are then created for both the systematic evidence review and the evidence-based guideline, with an ACMG methodologist as a member of both. The systematic evidence review for whole genome performs a robust working group, performs a robust systematic evidence review with meta-analysis as appropriate. These will then be published in Genetics and Medicine. The evidence-based working group will then look at these SEER results and with the methodologists use a grading method to develop recommendations. This too will be published in Genetics and Medicine. We'll go through the different steps that are involved in the systemic evidence review and go through this phase first, and then the guideline development. The stages are shown here. So you can see that it's a multi-step process, starting with a clearly articulated research question. Inclusion and exclusion criteria determined before the literature search is performed or studies are screened for eligibility. Once irrelevant studies are excluded, the included studies undergo both data extraction of relevant information and an assessment of the study's quality or risk of bias. The resulting data is then analyzed and synthesized using quantitative methods like meta-analyses or qualitatively in a narrative synthesis. Finally, the results of the SER are reported using a checklist to ensure transparency, reproducibility of methods, and completeness of the results reported. As shown on the previous slide, it's important to be explicit when formulating the evidence review. For example, the SER work group defined congenital anomalies to ensure that it was clear what patients the guidelines will be relevant for. Contrasting the fairly narrow definition for congenital anomalies is the broad definition that was used for clinical utility. Definitions of clinical utility differ based on the objectives of a study. Therefore, we consider not only patient-centered outcomes like changes in patient management, but also family-centered outcomes like changes to reproductive decision-making and provider-centered outcomes. You can see there the definition that was used for congenital anomalies, specifically structure or functional abnormalities usually evident at birth or shortly thereafter, and can be consequential to an individual's life expectancy, health status, physical or social functioning, and typically require medical intervention. The clinical utility, as mentioned, was more broadly defined. The initial stages of the SER included stating the population of interest. In this case, we're looking at patients with one or more congenital anomalies evident before 1 year of age, and patients with developmental delay or intellectual disability documented before 18 years of age. The methods used here these are often referred to as PCOTs for a systematic evidence review. So you can see there the population, intervention, comparator, outcomes, timing, and setting. We included studies if exome or genome sequencing were performed, regardless of the timing when they were done. For example, if they were early in the process or at the end of a long diagnostic odyssey. Only studies that explicitly reported an outcome of interest were included. But often, when we're thinking about genetic literature, often when we have publications, they describe the gene disease association and the novel findings associated. We often focus on diagnoses and not outcome nearly as much. So here you can see the PRISMA workflow chart from the systemic evidence review. So more than 7,000 studies were published between 2007 and 2019. And it's important to note those timeframes as well when the study was being initially done. The work group ultimately included 167 of the over 7,000 studies that they started with. The majority of these studies were case reports or case series with fewer than 20 patients, and included because they specifically included outcomes and not just describing the novel findings. The published SER manuscript focused on the reporting on the reporting of a single randomized controlled trial and observational study with 20 or more patients. Most SERs rely more on randomized controlled trials, but these are not a common investigational method for genetic disorders because of the rarity of conditions. Of note, the SER did not directly evaluate diagnostic yield of exome or genome sequencing, as several contemporary published works investigated yields and compared them to other testing modalities. This is a forest plot to show the overall proportion of patients that were included in the studies with a reported clinical utility outcome. You could interpret this as 9%, with a confidence interval from 6 to 14% of patients having a change in management, medication, family, or provider outcome. This does not reflect diagnostic yield, which may have been higher in many of these studies. But it's also important to but this also importantly may not reflect when testing would help out rule out something, such as if you had a patient who had intellectual disability and autism and macrocephaly, and where P10 has been ruled out and another diagnosis has been made, you may not need to do screening, which would impact clinical value to the patient. Once the evidence review has been completed, a separate work group began the work of translating the evidence into recommendation statement. In this case, we did include one person from the SCR just to allow for some institutional knowledge. The time gap between the end of the SCR and the beginning of the guideline project resulted in additional studies being considered as part of the evidence basis, and the diagnostic yield was obtained from meta-analysis done in part through the health and technology assessment by the Ontario Health Technology Program. Results from the SCR and other evidence were then put into an evidence summary table, example of which is shown here on the left. The EBG group used a great evidence to decision framework. And here you can see the domains that were assessed as part of the guideline panel. So we'll walk through the overview of the process. So the members of the panel would then each vote independently on the different grades that we discussed before. A consensus was reached for each domain separately, which you can then see on the left here. This also then helps to determine the strength and direction of the recommendation, which we'll talk about next. You can note in the green box that for the balance of effects domain, the intervention of exome sequencing or genome sequencing compared with no ES or GS had relatively few harms and several valuable benefits. Guidelines were then developed using this grade methodology that have both a direction for or against, as well as a strength, strong or conditional. Based on the totality of evidence, the ACMG strongly recommends ES or GS as a first tier or second tier test, guided by clinical judgment and often clinical patient family shared decision-making after microarray or focus testing for patients with one or more congenital anomalies prior to 1 year of age, or for patients with developmental delay, intellectual disability with onset prior to age 18. So again, important to note that we included clinical judgment and shared decision-making because of the value that this does have. And importantly, also patient values and preference. Going back specifically to the evidence that we used for this recommendation, we looked at it in a couple different ways. First, we evaluated the active changes to clinical management. This included changes to medications, such as stopping or starting a medication, or active procedures or surgical interventions. For example, a patient with intellectual disability or exome sequencing was found to have a pathogenic variant in SLC39A14, which causes a potentially treatable form of hypermagnesemia, which allowed the patient to be started on chelation therapy to improve their manganese level. In another patient with congenital anomalies, rapid genome sequencing led to a diagnosis of ABCC8-associated familial hyperinsulinism type 1. Follow-up imaging showed that they had a focal form of the disorder, which led to targeted resection to avoid development of insulin-dependent diabetes years later. Changes to long-term management recommendations or surveillance was found in about 10%, but several studies really showed it in more than 15%. For example, in exome sequencing for congenital anomalies and dysmorphic features, a patient who was suspected of having infantile Marfan syndrome was found to have an X-linked megalocornea due to a pathogenic variant in CHRDL1. This change in diagnosis meant that planned echo surveillance was discontinued. In a study of patients in the Illumina iHope program who received a diagnosis from a genome sequencing, 1 in 5 were given referrals to specialists to assess for comorbidities. Across the 167 studies that were included, the SCR work group found that many instances of people or families reporting changed reproductive planning based on the diagnosis from exome or genome sequencing. Across the studies with more than 20 patients, 20 of them actually reported changes in decision to become pregnant, terminate a new pregnancy, use reproductive technologies to undergo pre-implantation genetic diagnosis, use donor sperm or egg, or undergo previously unplanned diagnostic testing for an ongoing pregnancy, such as CVS or amnio. You can see here for the family-focused outcomes, only a few studies were noted simply because they were not included in other reports. But clearly, based on the information we have, the downstream consequences for family members can be critically important. It was very important to have a patient advocate on our EBG group, as this was important to keep in perspective. I'll provide an example from my own clinic of a patient who I've seen. So he was initially seen when he was 1 year old with hypotonia and developmental delay, but he had been worked up previously because of a history of neonatal cholestasis through sponsored testing, indicating he had homozygous variants in SERPINA1, indicating alpha-1 antitrypsin PZ alleles, as well as being a carrier for CF based on newborn screening. He had limited follow-up until he was admitted for liver imaging and noted then to have significant hypotonia. He was not sitting without support, had minimal scooting to get around, and limited interaction with others. He had an MRI at that time that showed hypomyelination equivalent to about a 6-month-old, which then leads to a fairly broad differential. He underwent exome sequencing, which identified a maternally inherited variant in an X-linked gene, SLC16A2. This is associated with a disorder called Allan-Herndon-Dudley syndrome. Going through the checklist we discussed before, and changes to acute management, nothing specific at this time, but he is a good example of a patient who would have been eligible for a research study. And more rare diseases are being treated, even as N-of-1 trials. In terms of long-term management, one of the things that would be important is that he does not actually need repeated MRIs, as myelination is delayed but does improve over time. For changes to family planning, parents were not interested in more children at this time. But in thinking about the specific family, it does provide the family with expectations of what his development will look like. Additionally, because this was inherited from his mother, females with this condition can actually be affected by hypothyroidism. And this mom actually did have evidence of hypothyroidism, though that this specific condition, they can also look like they actually have hyperthyroidism. So implementing this guideline, when might it be appropriate? So can you refer to a genetics evaluation? We are well aware of the lack of genetics access for many people in the United States, let alone around the world. And are you comfortable ordering exome or genome sequencing while waiting for a genetics referral? Prior authorization for testing is obviously an important part of this. But I think one of the most important things too is genetic counseling, both pre-test to manage patient expectations, but also post-test, as well as then getting into the interpretation of results. And then the questions of what to do when genetic specialists aren't available. Telehealth is one option that is becoming increasingly available. Obviously referrals to a genetic specialist whenever possible, and whether to start with other gene tests, whether it is microarrays or gene panels, which may be easier to do at the beginning. I'll also point out that these recommendations were specific, but have been taken by some different groups to be much broader. I certainly had some neurologists who have said that this kind of opens the door for neurology also to use exome sequencing as first-line testing. But again, pointing out that this was specific for children with congenital anomalies or intellectual disability or developmental delay. So in conclusion, SCRs provide the evidentiary basis for evidence-based guidelines. It's a multi-stage comprehensive evaluation of literature that includes studies with pre-specified inclusion criteria. Evidence from the SCRN studies published later showed few harms resulting from the use of exome or genome sequencing, and meaningful impacts on clinical management, long-term surveillance, family members, clinical management, and impacts on reproductive decision-making. Using the great evidence to decision framework, the guideline panel was able to create a strong recommendation, for ES/GS to be either first or second tier testing for patients with congenital anomalies or developmental delay. I'll point out also that this guideline was not meant to be dictative in how it allowed clinicians to practice, but rather to allow clinicians to practice as they see best fit. I want to thank the other members of the guidelines committee who are included here, as well as the American College of Medical Genetics Board of Directors. Go to questions.
Great, thank you so much, Dr. Manikam. We have a few questions in the Q&A, and so I'll read them to you, and if you'd like to respond. The first one is from Tara Jones, who says, I work in adult neuro and often get patients who have congenital anomalies that either never received genetic testing or never received answers from their genetic testing decades ago. I'm often met with insurance policies denying exome sequencing because my patient is over 21 years, even if they are of reproductive age. What can I do to make the case when the patient is outside of the policy guideline?
So the policy guideline actually says with onset before age 18. So the guideline does apply. This actually should allow your patient to get testing. Certainly adoption of the guideline by insurances is going to be an ongoing thing, but we wanted to provide the evidence that if the patient has congenital anomalies evident before age 1 or intellectual disability before age 18, then the guideline should fully apply to them.
Great. We have another question, in quotes, one or more congenital anomalies, meaning consider exome for isolated complex congenital heart defects or isolated cleft lip or palate.
Yeah, thank you for this question, because it is something we struggled with, because as you kind of indicated, that, we did open it up a little bit, and we do recognize that isolated complex congenital heart defects or isolated cleft lip and palate, both are not necessarily best served by having exome sequencing as a first line. I think we, again, wanted to allow clinicians to practice as clinicians, that you make a clinical decision that you think is best for this patient. It's hard to actually monitor that, I guess, is one way to think about it, that, you can't include things like dysmorphic features as well as having a congenital heart defect, but clearly that's part of the evaluation we're looking at. And so we did want to leave it kind of wide open with that, but it is absolutely correct too that isolated single disorders are ones that we do recognize exome has some limitations to it. Has some limitations of value, yeah.
We have another question. Tell us SNP microarray is not needed anymore.
That's a very good question. I think, again, this is an ongoing issue. You will notice also within these guidelines, we did not differentiate between exome sequencing and genome sequencing. I think with genome sequencing, we're starting to recognize that microarrays may not be necessary to look for deletions and duplications. There may still be some value for a SNP microarray if you're thinking about consanguinity as a potential cause. So again, that should be evident on genome sequencing that exome sequencing may not be able to pick up. But this is also technology based. So over time, this is going to get better. And again, the guidelines, we wanted to include that in some cases, again, depending on clinician and family preference as well, that it may be better to start with a microarray.
We have another question. Would you like to, well, I guess maybe it may be more of a comment, but would you like to comment on exome sequencing being able to detect uniparental disomy related disorders with higher specificity?
It could be, yeah, that certainly is. And again, it's an improvement in technology, both from how the next generation sequencing is being done, but also on the computational end, that there are improved programs to be able to impute some of these findings.
Great. Are there any more questions from the audience? All right, we have one. To clarify, is it correct that exome or genome sequencing can or cannot detect duplications or deletions? Can you clarify that comment?
Yes, so exome sequencing is not ideal for picking up deletions or duplications. And again, it's based sometimes on the technology and the computational portion to interpreting the testing. Genome sequencing is better at picking those up, but there are some limitations in that as well. I think you really have to also think about what you're looking for. There are certainly a large group of disorders, such as the triplet repeat disorders, that are not going to be picked up by exome sequencing and are kind of variable by genome sequencing, depending on the company and how they are interpreting some of the data. Again, with these guidelines, we want to be both broad, but also a little bit specific as to what we are trying to show evidence of. And we want clinicians to practice as best as they can and they use clinical judgment when necessary.
Great. So we have another question about if there is a plan for guidelines for diagnostic handles to exome or genome sequencing versus chromosomal microarray. So I guess maybe direct comparisons.
I don't know if you might be better to answer that, Jennifer.
Yep. Okay. So I will take that. As ACMG senior methodologist, we do not currently have a plan to create a guideline that specifically looks at the comparison of exome or genome sequencing to chromosomal microarray. However, where we have disorder-specific projects in place, we will look at the diagnostic yield between the two or between the different modalities. And then if there is sufficient evidence, we can make recommendations based on that evidence. But I don't know that there is a plan right now to just do a blanket exome genome sequencing versus chromosomal microarray. We also recognize that there are some limitations, as Dr. Manikam has already described, to exome and genome sequencing. And so as the technology continues to improve and what can be identified through those methods changes, then certainly the impact of CMA may change over time. So we have another question asking, what is the best test for del and dupes, deletion and duplications?
That is a great question. So I think it's a little bit of a moving target, and I think it depends on the test company and how you're doing your testing. Whole genome genome sequencing certainly does have a better ability to pick up deletions and duplications, but we've had recently at our institution a case that we found a single variant and we couldn't find the second variant, and did whole genome sequencing on both a research and clinical basis that initially did not identify it. Interestingly, the mom then had prenatal screening done, carrier status, which included del dupe, and they picked it up to find the second variant in her other child, as it turns out. So I think it is kind of one of those that there is no simple answer for this. I think one of the things that certainly we've thought about much harder is when you have an autosomal recessive disorder, you find one variant, it's maybe trying to hunt for that second variant. Sometimes they will be intronic and sometimes they will be deletions, duplications. And so sometimes making the focus of the secondary testing that you're doing to look for del dupes may be one method. And you should also consider, how common are deletions, duplications in certain conditions when you're considering that as well.
Great. So we actually have enough time that if participants would like to raise their hand and ask their questions directly to Dr. Manikam, please do so, and we'll call on you one at a time. But I will go ahead and proceed right now with the comments or the questions that are in the Q&A queue. The next one is, if in the future newborn whole genome sequencing is implemented as a routine test, these policies will need to change because the data will be available in the clinical record. And you'd like to know what you think about that.
I do agree. I don't know when that is going to be, that it becomes routine to do whole genome sequencing. And I think it comes to another question that's a little bit further down too. You know, the responsibility we do have, and we did address this in the paper, that it is important to go back and look, even if you do have a diagnosis, but maybe more so when you don't have a diagnosis, to look back at the data and reanalyze. We've certainly seen, and multiple papers have shown, that our ability to diagnose improves significantly year over year. Sometimes it's because of improvements in just the fact we know about a gene that we didn't know about before. But also I think that technology also changes. And so, Exome that was done 7-8 years ago would be quite different from Exome that's being done today. So I think that's part of it. I think, there are lots of issues with doing, I think, genome sequencing, as routine, quote unquote, on newborn screening. I think that we are going to have issues with variants of uncertain significance. How do you think about those as we go forward? I think it's one thing if they're already routinely seen in a genetics clinic or followed by a genetics professional, that the VUSs are reanalyzed or rethought about at least. But when it's part of newborn screening, is it going to be that same process? And who knows? It is kind of a, it's going to happen, but when it's going to happen, it's going to depend a little bit on our ability to get better about interpretation, but also follow-up.
Great. One of the attendees would like to know about pre-authorization approval from payers and whether or not it's easier to obtain that pre-authorization for chromosomal microarray versus exome or genome sequencing following this guidelines publication.
I think this is actually something that the ACMG is going to do as a survey to see the impact of these guidelines on the ability of clinicians to actually practice. Is it becoming easier because these guidelines are out to get approval? I think anecdotally we've heard from several people that it has become easier, but I think to do it as a survey will yield some important information as well.
One of the other attendees asks if you have any thoughts on the use of optical genome mapping.
I do not, though I know it is quite an interesting area that is certainly growing in value.
One question is whether or not we're looking at prenatal exome sequencing also.
That was not addressed as part of the initial systematic evidence review. Especially when you consider, again, that time frame that we were talking about from about 2009 to 2017. There were very few papers out at that time about prenatal. I think the literature has started to increase, and it's certainly something that can be addressed over time. I would also point out, I think one of the limitations I think we see as clinicians is that you don't necessarily have a full clinical phenotype for in utero diagnoses. And so it's not always quite evident. And even, with the guidelines we've established here, where we're talking about congenital anomalies before age 1 and intellectual disability before age 18, things change over time. Phenotype changes, and phenotype can help with interpretation of variants of uncertain significance. And so I think that is one other limitation you're going to have with prenatal testing.
Great. A couple of people have asked you to address the question about who's responsible to inform families about new research revealing changes in status to those previously identified variants of unknown significance.
That is a great question. I think very much, again, one of these things that we're kind of learning on the fly. I think, we have responsibility as clinicians to go back and look at patients' information. But it's also difficult to do this on every single patient that we have done prior testing on. Some of this also falls to the families that they need to follow up after testing is done, because it does allow us an opportunity to go back and see whether it's worth considering other things, whether it's reanalysis or looking at previous VUSs to see whether they've been reclassified, or is there something changed in the phenotype so that we can improve the interpretation.
Great. We have another question asking what the best approach for finding early or quick answers for identifying intellectual disability might be.
Again, an important part of what we're looking for. I think that one of the things I think we have to think about carefully here is recognizing that with intellectual disability, it is sometimes more prognostic information, and that may not have as much value in looking at clinical utility from immediate management. But I think you can think about it for long-term management. You can think about, I think a good example of this would be even when you give somebody a diagnosis like Down syndrome, that you can kind of start to create realistic expectations for the family as to what you expect as an outcome. And I think this is where the value may be for some children with intellectual disability, simply because there aren't a lot of specific treatments that might be available. There are going to be some inborn errors in metabolism and some disorders such as the one we shown with the hypermanganesemia. But I think they're going to be the exception rather than the rule. But there's obviously both the benefit to the patient and the family to have expectations, but also the recurrence risk.
Great. Do we have any more questions from the audience at this time? If you'd like to, you can raise your hand using the Zoom button at the bottom of the Zoom window, or we could answer through the Q&A. So this question is, what is the best approach for finding, this is a follow-up. So that would mean that early exome sequencing may not be a good answer, or even newborn screening as far as finding an earlier quick answer to identify intellectual disability.
Oh, no, I think it is a good answer. I think what we are saying is exome and genome sequencing is a good answer for many patients. But again, the knowledge base is changing over time. So I think the more the utility side that may have some limitations.
Great. So we have a comment sort of question about a managed care Medicaid provider stated that they did not consider testing for reproductive risk to be a program benefit. And then a second objection was that they demanded a specific disorder requiring change in management prior to authorizing what they considered to be a fishing expedition. Would you like to comment on that?
Yeah, love to comment on that. Sorry, Jennifer, can you leave the question up for just a second? What do you think about that? So the first part was, sorry, let me pull it up here so I can look at it and specifically address it. The program benefit issue is interesting. The average American spends only about 3 to 5 years, if I recall the numbers correctly, on a managed care plan or on a health plan. So if you are thinking about long-term benefits, they really don't get the long-term benefits. So it is one of those things of, for that specific plan, they're not getting the benefit, but there is this idea that everybody gets the benefit, that if they're on a different plan, that plan will still benefit from the information. There are also certain insurances that have very specific clauses about things like this that they include, and that kind of goes into what the rates are for different plans. And so it sometimes is a specific exclusion that I think we'll have to see what happens over time. And then the idea of, a specific disorder requiring change in management before a fishing expedition, we don't know until we look. And so I think, you look at the numbers that we did find, I would say that 10% is both really encouraging and a little bit discouraging, but that is what we found. And for 10% of families, okay, immediately we're able to make a change, whether it's a medication or something else or a specific treatment. But that number, I almost guarantee, is going to be improved now if we were to look at the current data. I didn't say it also explicitly during the presentation, but I really want people to take to heart this idea of when we report things, we really need to include the clinical utility. We need long-term studies that show that, because that's what is going to show this long-term value.
Great. We have another question asking if genome sequencing can detect trinucleotide repeats and imprinting disorders.
So for trinucleotide repeats, it is definitely an issue for computation. They can be picked up, but it really depends, I think, on the programming and how the variants are being interpreted. And there are definitely differences, different platforms. I think long range sequencing is superior to some of the short read ones. And so I think that is one part of it. Imprinting disorders are ones that, it kind of depends on the disorder and also, again, on methodologies, but they may be ones that are not easily picked up by a lot of the current technologies.
Great. So we have no other open questions right now. So I'm actually going to ask you one and put you a little bit on the spot, which is, you brought it up in one of the slides talking about what to do if there isn't, maybe easy access to a genetics professional nearby for a patient. And certainly certain areas of the country may be more affected by this than others. Can you give maybe some more concrete examples or suggestions on what our non-genetics healthcare providers can do?
Yeah, I think there are a lot of options. So one is that, I think there are a lot of centers that are doing telemedicine. We're a little bit limited by our state laws. So within a state, hopefully that there are some professionals who would be available by remote access so that we could get telegenetics, within the hospitals or as an outpatient center. Excuse me. I think one of the other options would also be going through some of the test companies that do provide genetic counselors. A lot of them now have genetic counselors that are part of their system and can provide some of the pre and post test counseling. But I do think that there is a lot of value in seeing a clinician to do a really good phenotype, which will then help with interpreting test results.
Great. We've gotten a few more questions in the Q&A. One is, I guess maybe more of a comment, but triplet expansion, methylation disorders, aneuploidy determination, et cetera. Basically, we still have a need for other tests. Those other tests may have additional clinical utility more than just detection of the few extremely rare mutations with unknown penetrance.
That is absolutely true. And again, we want to, with these guidelines, allow clinicians to practice to the best of their ability. If you have a child who you think may have a trisomy or something like that, you're going to get a result like that back faster in most cases, not all cases, but in most cases by doing a karyotype, a stat karyotype, rather than waiting for an exome or genome to be done. But I will also say that I'm an advocate to always consider other diagnoses. And just because a child has one diagnosis doesn't mean they don't have a second. And so we should always also keep that in mind when thinking about if they've had a karyotype, that maybe there's still some value to do an exome if the features don't quite all fit.
Great. We have another question asking about moving from genomics to proteomics and what that might look like if we're using protein sequencing methods. Any comments?
I have no comments because I'm not sure where that's going to fall. Yeah.
Okay, great. If there are no other questions, please feel free to put them in the Q&A right now or raise your hand if you'd like to ask directly. Oh, here we go. What is a reasonable time frame to expect for exome or genome sequencing to be completed?
That's an interesting question. I don't know. reasonable is also a very open term. I think there are a lot of programs out there that are doing rapids, whether it's days to weeks to get back results. And I think that there is certainly value in getting a rapid back. I do worry a little bit about the depth of coverage, so to speak, for rapids in terms of not the quality of depth of reads, so to speak, but more of just like the thoroughness of going through variants and being able to analyze them. You're much more dependent on computers and those kinds of technologies for variant interpretation. I certainly find it really valuable within our own institution when we are part of the interpretation of test results, because I think that there is added value when we can give our own opinion about the variants. So, for a turnaround time, it's going to be dependent on the center that you're using, the lab that you're using, but I don't think it's the only thing to get back a quick result. I think that there's a lot of value with making sure it's a thorough result as well.
Great. We have another question asking about using exome and genome sequencing and potentially even microarray for syndromic congenital anomalies, not just the non-syndromic. So would you recommend that would be something that should be at least maybe considered for both?
I would say it should be considered for both, but again, going back to that question at the beginning about, isolated cleft lip and palate and what we should be doing for those kinds of patients. We know that there's limitations on the value of an exome or a genome at this time for isolated cleft lip and palate. And so clinical judgment should be part of that as well.
Great. We have a question asking if you envision the $100 genome with interpretation of results, and if so, how long do you think it'll take us to get there?
So there's a company that I think now says they'll do the $100 genome just on the basis of just doing the testing, but I don't think we have quite gotten to the interpretation part to be that inexpensive. I don't know when that's going to happen exactly. I think, it's going to be like anything that you're paying for the value of what you're getting. And, you don't want to just do a test because you have a test result. You want it to be a test that actually is accurate and, hopefully helpful to you. So, as Bruce Korf has pointed out before, having the $1,000 genome and $10,000 interpretation is kind of part and parcel of this to interpret it. And I think also, again, the value of reanalyze that information over time. And the $100 genome, the quality may not be always optimal if you want to do some kind of reanalysis or look for trinucleotide repeats or other things as the technology improves.
Yeah, alongside that, do you have any idea about an actual cost to a lab to do one of these exome or genomes? Sort of like what the actual cost is versus what the retail costs are?
I don't know, because I think there's a lot of variability still there, because I think, it depends on how much they paid for the machines and technology and the number of people who are involved and things like that. So I think there's a lot of variation there, but certainly it's a very competitive space.
Great. We had a comment that acknowledged that as you brought up before, people with one disorder may have another. So in the case of someone with Down syndrome, they absolutely could have another disorder. And then we have another question asking about SCA, I'm assuming that's autosomal dominant triplet repeat disorders, what the impact might be of a homozygous pathogenic expansion. And if it is there, could it slow down the manifestation considering age of onset?
That is well outside my area of knowledge. I think you may need to talk to a specialist of that area to get an answer like that.
Okay. Well, fantastic. I don't see any more questions. So I think as we wrap this up, I might just ask you, Dr. Manikam, what would be the sort of the takeaways that you really want the viewers of this webinar to take home, and some maybe something that they can do very concretely for their patient populations?
Yeah, again, I'll go back to our conclusions a little bit. Maybe that'd be an easy way to start with. To make people aware of what what the evidence-based guidelines really are talking about here. Again, that it is to congenital anomalies and to intellectual disability, but that exome and genome sequencing absolutely have value for that patient population. And again, I will also emphasize that I think it's really important for us as a community to think about, with publications, thinking about this long-term impact question, that we need to show in our articles and so forth that there are specific values to this. It's not just the association of a gene with the disease, certainly important, but that we need to start looking at the long-term benefits in clinical management, surveillance, other families, the family's own personal experience with this and reproductive decision-making. But I also think that's really important. And, I think one of the things that really this is about too, is that you really have to use the correct framework in order to get to these answers. There are guidelines out there that are expert consensus, and those are absolutely valuable. But I think when you can show the evidence basis through a very specific methodology, that it just strengthens so much more, and really it will drive payers to pay when we can show that it's been done in a very well described and well reproducible manner.
Okay, great. Well, thank you, Dr. Manicam, for this incredibly impressive webinar. Your presentation was incredibly helpful. We had some really fabulous questions that we were able to have answered from the audience. So we really appreciate all of your insights into this. I would like to just make a note that we will have a follow-up for this webinar series on July 25th at 4 p.m. This will be sort of a 201 version of this seminar, and it will be a deeper dive into the evidence specifically and the science behind what we did to create this evidence-based guideline. We'll have Dr. Lori Demmer, who is Chief of Genetics and Metabolism at Atrium Health's Levine Children's Hospital, and Fuki Hisama, Dr. Fuki Hisama, Professor of Medicine in the Division of Medical Genetics from Seattle Cancer Care Alliance, as our speakers that day. So we certainly encourage you to sign up for that webinar as well. And that was all. We really appreciate everyone attending today's call. The recording of this will be posted in the Genetics Academy, and we encourage everyone to complete their CME requirements in order to obtain CME for today's webinar. Thank you so much for attending.